What's at Stake for the ACA in 2015. My name is Ian John, and I am the Senior Policy Analyst with the Asian and Pacific Islander American Health Forum, based in our San Francisco office. For those of you who are not familiar with the Health Forum, we are a national nonprofit organization with a mission to influence policy, mobilize communities, and strengthen programs and organizations to improve the health of Asian Americans, Native Hawaiians, and Pacific Islanders. And before we get started, I'm just going to go through a couple of housekeeping items. So first of all, this conference, this webinar is closed to the press and not for press purposes. All of the participants will be muted by our webinar administrator here. And I would encourage you all, as you're listening to the speakers, if any questions pop into your head, please use the chat box, the question box, to type in as you think of something, and we will have a Q&A period at the end after the speakers finish to go over those questions. As I mentioned, we're recording this webinar, and it will be available next week on our YouTube channel. We've put the link up there to how you can access the recording, so please tell your friends and colleagues for those who weren't able to make it today. We're also going to be live tweeting this webinar. And those are the accounts that we'll be tweeting from, our Health Forum and Health Forum Policy account. And if you would like to tweet as well, please use the hashtags that we've listed up there, King v. Burwell and ACA Challenges, if you'd like to join in the conversation. So with that, to get us started, I'd like to introduce the President and CEO here at the Health Forum, Kathy Cochin, and she's going to provide a short overview of the ACA-related work that we've been involved with over the last year, and then introduce our special guest speakers. Kathy?
Thank you, Ian. I'm very excited to be on this webinar with you all today because we have two very special guests, Ron and AJ, who are really good friends to the organization. So I really want to thank them both for taking the time out of their busy schedules to join us and to really help us understand and think about where we're going and what's at stake with the ACA. But first, let me just give you a snapshot of what we all have been doing across the country. The Health Forum, along with APCHO, the Advancing Justice AAJC, and Advancing Justice Los Angeles partners, helped to create Action for Health Justice, which is a national network of 70 community-based organizations and federally qualified health centers all across the country that are helping to do outreach, education, and enrollment assistance in Asian American, Native Hawaiian, and Pacific Islander communities. Originally, it was formed to help with enrollment for the ACA, and now has really grown to become a network for civil society. So not only doing the ACA work, but also voter registration and get out the vote work, as well as informing and helping to register people for DACA, the Deferred Action for Childhood Arrivals, and DAPA, Deferred Action for the parents of citizens. And we are very, very proud of the work that Action for Health Justice has been doing for the last 18 months. So much so that the call, just this week, we got recognized by the Vice President and in particular the Surgeon General on a call to continue to rally the troops for round 2 of the ACA enrollment. So to give you a sense of the size and scale of Action for Health Justice, our partners work in 22 states all across the country, and here you can see in this slide the variation between state-based marketplaces, many of the federal marketplaces, and the few partnership marketplaces as well. Among the accomplishments for round 1 for Action for Health Justice is that we reached over 600,000 people across the country, and in fact helped to assist enrollment for over 232,000 individuals. And then for round 2, our goal is in half the time for the enrollment, open enrollment period, we still have a goal for 200,000 people receiving enrollment assistance. And certainly one of the hallmarks of Action for Health Justice is the language access, and that services were provided in over 40 languages, and here you see what they all were. I really believe that without Action for Health Justice, that those nearly 250,000 people really would not have been able to otherwise enroll in the health insurance expansions of the ACA. We continue as a network to not only do the work on the ground, but to also continue to push the CMS and the Secretary Burwell, to make sure that there is adequate language access through healthcare.gov, through CMS, and through the state-based marketplaces as well. So again, I'm very, very proud of Action for Health Justice and want to acknowledge all those who are listening in who have been a part of the really, really important work. Let me now turn to our speakers. Again, I'm so thrilled to have both Ron and AJ participate with us. First up is Ron Pollack of Families USA. Ron is the founding executive director of Families USA, a national organization for healthcare consumers. Families USA's mission is to achieve high-quality, affordable health coverage for everyone in the United States. And in this capacity, Families USA was the critical player in getting the ACA passed as legislation, coordinating the on-the-ground efforts in every one of our states. Ron is also a visionary and is the founding board chairman of Enroll America, the national effort that is securing optimal enrollment of uninsured people through the ACA. Ron is a frequent guest on national television and radio programs, and we're really honored that he is speaking today with us. So Ron, can we ask you to speak about King v. Burwell?
Well, thank you very much, Kathy. It's a delight to be with you and Ian and with my good friend AJ on this webinar. You know, I'd like to be talking about a very happy subject, but King v. Burwell does not quite fit that category, but it's a very important thing for all of us to focus on, because I'd say, as succinctly as I can, King v. Burwell is the most significant existential threat to the Affordable Care Act in about 36 states. So what is King v. Burwell, and why is it such a threat, and what happens if the Supreme Court, which is scheduled to hear oral arguments in this case on March the 4th, what would happen if the court rules in a way that we hope it does not? What this litigation is about, it's really part of a series of 4 lawsuits that were brought by opponents of the Affordable Care Act, inspired by a group called the Cato Institute. And it is designed to eliminate tax credit premium subsidies in all of the states where the states have not chosen to directly run the marketplaces, these so-called exchanges. According to the plaintiffs, the petitioners in this case, they argue that the statute prohibits the federal government from providing tax credit premium subsidies in any state that refused to set up its own exchange. And since there are about 36 states across the country that refuse to do so, largely because the governors and state legislators wanted to show their antipathy to the Affordable Care Act, there is a great deal at risk here. Now, I have to say at the outset, one of the clear indications of why this is so concerning. Supreme Court decided to hear this case, even though hearing this case, putting it on the docket, is very contrary to the typical guidelines that the court uses for what cases it will hear. Let me pick up 3 of those guidelines so you understand what I'm talking about. This case, King v. Burwell, raises no constitutional issues. These are all so-called statutory issues where the claim is that the federal government is violating what Congress enacted, i.e. the Affordable Care Act. Normally, the court is more apt to take a case where there are significant constitutional issues at stake. Here, there are no constitutional issues at stake. Secondly, the court typically likes to hear cases where there are conflicts between the circuit courts of appeals. So that the Supreme Court then would be the arbiter of the differences in judgments by the circuit courts of appeals. Here, there is no conflict between the circuits. And so that is somewhat surprising. And perhaps most peculiar is that since this was a series of 4 lawsuits, in 2 of the cases, the relevant circuit courts of appeals, the Circuit Court of Appeals in the District of Columbia and the 10th Circuit in Denver, had already scheduled oral argument on these very issues. And despite that, the Supreme Court decided to leapfrog what would be hearings in those cases and decided it would hear this case prior to those circuits having a chance to hear oral arguments and render decisions. So obviously, there are some justices who are really eager to put their hands on the Affordable Care Act. Now, mind you, the decision to place this on the docket, it's what we lawyers call a writ of certiorari, was accepted by the court. It only needs 4 justices of the court to grant a writ of certiorari. So that doesn't mean you've got 5 justices right now who decided they wanted to place this on the docket. But it's worrisome that 4 justices place this on the docket, especially for the reasons I mentioned. This clearly violates the normal guidelines that the court uses as to what cases it would raise. Now, let me give you a sense of how potentially harmful this would be. And last week, we saw analyses issued by the Urban Institute and by the RAND Corporation that provided clear indication of what the harm would be. According to the Urban Institute said that if the court rules for the plaintiffs, the petitioners in this case, that 9.3 million people would lose tax credit subsidies, 8.2 million people would join the ranks of the uninsured, and premiums would rise by 35% for those people who are getting coverage through these marketplaces. And I'm going to explain why that happens in a moment. But I wanted to give you the comparable numbers from the RAND Corporation, whose projections are even worse. The RAND Corporation estimated that enrollment would decline by 9.6 million people, and that premiums would rise by 47%. That's a huge increase. Now let me get back to what I would refer to before about premiums rising. If subsidies are withdrawn, then, and it's going to make it very difficult for people to afford premiums, the people who are most likely to find some way to come up with the money, beg, borrow, steal, in order to keep their coverage, are people who have significant disabilities or health problems, chronic health conditions. The people who are less likely to continue getting coverage are those people who are younger and healthier, and young people actually receive a disproportionate amount of these subsidies because the subsidies that are now provided are provided on a sliding scale. The lower your income, the higher the subsidy. And young people tend to be in entry-level jobs, or they may not have a job, and so they are right now receiving the larger subsidies. So when those subsidies are withdrawn, we're going to see younger and healthier people drop out of coverage. And guess what happens? When you have older and sicker people who get coverage, but the younger, healthier people drop out of coverage, then the overall per-person costs of the insurance pool are much higher. And that's why costs are going to skyrocket. Now, I want to just talk a little bit about why I think this lawsuit, from a legal perspective, is specious. One of my backgrounds, frankly, sorry to say, I'm a lawyer. I used to be a law school dean. I've argued cases in the Supreme Court. So obviously, this is of special interest to me. But here are three clear reasons in my mind why this is really a specious case. Now, when I say it's a specious case, it doesn't mean that the court is going to treat it as a specious case, and it doesn't mean that it isn't a real threat to us. The first one is it is clear that the people who wrote the Affordable Care Act never intended to establish what we call conditionality. That is, that the condition for people in a state receiving tax credit premium subsidies would be determined based on whether the state decided to run its marketplace, its exchange directly, or whether it allowed the federal government to do so. In fact, there will be a so-called amicus brief, a so-called friend of the court brief, filed by each of the committee chairs, who are the committee chairs of the 5 relevant committees that wrote the Affordable Care Act. And they will be saying very clearly that we never established any kind of conditionality. And they obviously oppose the potential adverse results of this lawsuit. The second reason is that the Affordable Care Act was written sort of like a three-legged stool. What do I mean by a three-legged stool? Well, the 3 legs of the Affordable Care Act are, one leg is the prohibition that does not allow insurance companies from denying coverage or charging a discriminatory premium to anybody with an adverse health condition, disability or disease. Now, in order to make that work, the second leg of the stool was to make sure that other people actually bought insurance. And for that reason, the legislation created a mandate that people, if they can afford it, must buy insurance. And the third leg of the stool was to enable people to afford it. And that is to provide them with subsidies so that this requirement that they purchase coverage is realistic. You knock out any one of those legs out of the stool, and the Affordable Care Act really cannot function anyway near the way its creators had intended. So the opponents of the Affordable Care Act know this well, and it is their hope that if subsidies are withdrawn in the 3 dozen or so states that have not set up their exchanges directly, it is going to create havoc. As I mentioned, there are millions of people who are now getting coverage, who are going to rejoin the ranks of the uninsured. And for those who feel they could still purchase coverage or get coverage, premiums are going to skyrocket. So it is going to be difficult for people to afford that coverage. So what does all this mean? What happens if we lose? Bottom line here is that it will truly create havoc in the states that are affected. We don't know ultimately precisely how many states are affected. We know at least 34 states are affected. It may be as many as 37 states. I'm presuming many of you on this call are from California. California will not be affected. But the other states, and they tend to be the more conservative states, they will be affected. And it's going to mean that if the court rules adversely, we're going to have to work really hard and really quickly to try to get states to decide that they want to run their own exchanges. And I'm not sure whether time is going to really permit us to get this done. When the court rules sometime in June, most state legislative sessions will have ended already. And there are a number of governors and state legislators who are really opposed to doing anything that cooperates with the Affordable Care Act. I want to mention one other relevant matter to this. Many of us have been working really hard in states across the country to try to make sure that the Medicaid program would be expanded. There are 23 states in the country right now that have not expanded their Medicaid programs. And it wouldn't surprise you, I'm sure, to know that there's a tremendous overlap between those states that have not decided to expand Medicaid with those that are refusing to run their own marketplaces. And so it's going to mean that the work all of us have been doing to try to expand the Medicaid program so that the poorest of the poor can truly gain access to health coverage, this will complicate those efforts significantly because we're going to be fighting two wars at the same time. One is to try to get the Medicaid program expanded, and the second is to get the states to decide that they should run their exchanges directly so that these premium subsidies can be made available. Bottom line is that we've got real danger here. And AJ is going to be talking about what's happening in Congress. If we lose here in the court, it's going to give the opponents of the Affordable Care Act in Congress much greater leverage to try and cut the Affordable Care Act in a variety of ways. And AJ, I'm sure, is going to explain that. So thank you so much, Kathy and Ian, for allowing me to be on this webinar, and I'm delighted to wait to see if there are any questions.
Thank you, Ron. Yes, again, if you would like to ask questions, please include them in the chat box online. We're going to take Q&A after both speakers present. So thank you so much, Ron. That was really, really insightful. Now, and I also want to let you all know that we're very excited at Action for Health Justice that we are also preparing an amicus brief to submit to the Supreme Court for King v. Burwell to really bring forward the voices and stories of Asian American, Native Hawaiian, and Pacific Islander communities. We were able to do that at the Health Forum 2 years ago when the ACA, those 3 cases came before the Supreme Court, and we're really excited that we're doing that again with our Action for Health Justice partners for King v. Burwell, too. So let me now turn to our second speaker, A.J. Jones. Ranson Steve Jones II, or A.J., is a principal at the Podesta Group in Washington, D.C., and serves as chairman of the firm's healthcare practice. He serves as a lead policy and political consultant for Fortune 500 companies, national nonprofit organizations, and global foundations. AJ is the firm's first African-American health practice chairman and the only African-American health chairman of a top-ranked lobbying firm. Additionally, he serves on the firm's management committee and is co-chairman of its investment committee. Before joining Podesta, AJ was director of policy and research for former House Majority Whip Representative James Clyburn and served as his lead policy advisor on issues including health care. And AJ also served as the health policy director for the Congressional Black Caucus. AJ has been a wonderful friend and supporter of the Health Forum, and we look to him often for guidance and advice and strategy. So we're really happy to have AJ give us a perspective on the new Congress and their role and the potential impact on the ACA in 2015. AJ?
Well, first of all, thank you so much, and I am exceedingly humbled and also honored to be here today with all of you. And anytime that Kathy extends an invitation to me, I am both delighted and also grateful because I know it's about moving the country forward and ensuring that health and access are improved for all Americans, and particularly for the API community. So thank you so much, Kathy, for your unwavering leadership and unequivocal commitment to excellence as well as to equity for all. So thank you for that. I am also obviously grateful for the chance to be able to talk a little bit about Capitol Hill, but more importantly to talk about some of the issues that are going to be percolating through Capitol Hill as it relates to healthcare reform. what will be of great interest, as you can imagine, is the fact that healthcare will be on the docket all day, all the time. And it will be interesting from two different perspectives. The first is that for a long time, if you will, since the passage of the Affordable Care Act, which, by the way, for those of you who are marking your calendars, we are going to be celebrating the 5-year anniversary in March of the Affordable Care Act passage. The question has always kind of been, will it survive? And so far, under severe attacks from the day it passed, it has. The real question is, will elements of it survive in such a way that will make it workable or not? And clearly, my good colleague Ron has highlighted one that should that case go either way, quite frankly, it's going to create certain dynamics, but definitely if it goes in a negative way, it's going to create some very severe dynamics, mainly which now all of a sudden the Congress, whether they like it or not, will have to be compelled to actually legislate in this area in terms of bringing clarity to what are the Supreme Court rules. So first up in the docket will be, if you will, Republicans having to position themselves on exactly where they fall on this issue, particularly as it relates to the subsidies and how the subsidies are going to be playing themselves out. What should be of note to you, and I will share this with you, is that the Republicans have their policy retreat, if you will, January 14th and 15th, and they have dedicated almost 4 hours to the question on health care. So clearly there is going to be some engaged discussions about this issue overall, but I think they are also recognizing that the campaign to either repeal or dismantle has to have some sense of thoughtfulness through it, because if one does not, the dynamic one runs into is dealing with what we're dealing with now, which is where do Republicans actually fall on subsidies, particularly if they're going to be taking away from people. Because as I've often mentioned, subsidy members of Congress get elected on what they give the people, not what they take away from them. So just to start with that. The second piece I wanted to kind of raise, though, that I think has been on some people's minds, but I know is particularly of acute interest to those of you all who are on the phone, is we are facing a certain dire situation with the community health centers. As many of you may know right now, the community health centers are facing about a $3.6, $3.7 billion cut because of the need for renewal of a provision within the Affordable Care Act. It is unclear as of right now exactly how that's going to be resolved. There have been conversations about whether or not the paying for that, in order to be able to pay for that, should that come out of some element of Medicaid, whether it's in the FMAP matching or something of that nature, or should it be just done in an unpaid for fashion. Obviously, whatever fix that's done would require an amending, if you will, of the Affordable Care Act. So it would put Republicans on record for either adjusting or trying to fix the Affordable Care Act, which does make it a bit difficult from them from a messaging standpoint, given the fact that so many of them have been so vociferous in terms of being able to repeal it and not wanting to fix it. The second issue that I think that is of some interest and people may not be following because it doesn't fall neatly in the wheelhouse, but I think is of a great threat, is right now the Congress is considering on whether or not they are going to repeal the medical device tax. Now let me explain this for a second. There was a tax that was put on medical devices as a way of being able to pay for, as a cost saver, to help pay for the health care bill, expecting the fact that medical devices will be able to have an increase in costs, increase in consumption, and so that increase in consumption would then naturally lead to more revenue for those companies, and so those companies should then be paying a tax to funnel back into allowing for health care to be expended to our individuals. There's a strong likelihood that will pass through. The question is how it gets paid for, and if that tax is effectively not paid for, or right now, at least some of the plans by the GOP conference is to take it out of other areas within the Affordable Care Act. Many of the discretionary programs that many of us have championed for and been fighting for in the Affordable Care Act, from issues like data collection all the way down to issues like health professions training, will not have the funding that they need because they effectively will be now filling a hole that would be created by the medical device tax being repealed. Just to put it in a better sense, that device tax is about 29 to $30 billion over 10 years. So if you think about it, some of that tax is actually at a higher rate because the tax didn't go into effect until almost 2 years into the Affordable Care Act. So you're almost looking at maybe about a $4 billion a year take if that is repealed. And right now it looks as if Republicans have their way, they're going to try to take it out of there. That is going to be an issue for Democrats because there are Democrats who went on record voting for it during a budget resolution debate last Congress where you had 14 Democrats who voted in favor of repealing the tax. Now, it was a non-binding vote, but it was still a binding vote. That would give that particular provision a veto-proof majority in the Senate, and it already had a veto-proof majority in the House. So I do think this is of some sense a severe threat. I don't know if, and I'm concerned that many of us who are on the public health side maybe have not been following it as closely as we need to, but we should. The next piece that has been talked about, and Ron kind of alluded to this to some degree, is this question around CHIP. The Children's Health Insurance Program, obviously it has an expiration at the end of September of this year. There were efforts, valiant efforts to try to reauthorize it before the Congress ended, and that ultimately fell short. So there's going to be an acute exceeded focus, if you will, in reference to this. That being said, there are a number of changes that Republicans have advocated for in the past, and we are aware of right now in reference to the extension around CHIP. And then there's a bigger question about just the length of extension and what it will do. Now, obviously, there's what they call the kid glitch in it, and I'm sure Ron can speak ad nauseam about that. But just in a very brief situation, effectively, if in order to be able to fix the kid glitch, members of Congress, Republicans in particular, would have to amend and fix the Affordable Care Act. Again, putting them on record for amending and fixing the Affordable Care Act as a way of also being able to salvage and take care of CHIP. At least for right now, it is unclear exactly where Republicans will go. There also is a feeling that Republicans definitely will address immigration provisions that are currently residing in CHIP, and things like ACA and others could be under some severe threat and severe pressure. And so that is something of an issue to kind of consider there. The next will be the doc fix. As you all may know, that is kind of immediate and right in the lens of addressing, mainly because the doc fix as it is right now expires in March, and there is a real concern on exactly what happens there if another patch is done, as it has been done since 2003. I believe we're on the 18th patch of addressing, fixing the fee rate, if you will, that medical professionals are paid, and also the extending of certain types of billing and also funding procedures as it relates to certain types of services. If that is to be the case, that patch would right now clock in, depending on how they structured it, but will clock in just under $40 billion. And so there's a real question on what should be done here. However, a permanent fix, at least for right now, would cost about $140 billion. So Congress does have to make a decision there in reference to that. There is a concern, however, that the subsidies that are in the Affordable Care Act could come under threat as a way of helping to pay for either one of these fixes, and that could be obviously of an acute problem should that wind up becoming the case and wind up being the case. The next I would like to talk about is on the mental health side, and I just want to kind of point this out because this is something that I do know many of you on the phone have also been kind of focused on it as well, and that is looking at some changes, if you will, in reference to mental health services and their conjoining, if you will, with the Affordable Care Act. As you know, it has been of a great desire to try to bring mental health services in a much more mainstream structure in terms of medical services. And as a result, there have been a number of members who have kind of pushed, if you will, for the need to do that post the school shootings that have taken place across the country, et cetera, and mental health seemed to be the place of compromise, given the fact that the Congress couldn't find an area of compromise on gun control writ large. Right now, it looks as if there are a few Republicans who are very much interested in trying to pass a various set of mental health legislative pieces. So this may be an area where there might be some sense of bipartisanship. The question will come down to the extent to which mental health services are actually covered much more broadly within the Medicare structure, and to what extent that they are going to be required to be covered, if you will, within the exchanges, particularly under the essential health benefit structure, which currently right now has not been readily identified, or I should say has not been settled, if you will, even at the federally facilitated exchanges. The latter piece that I'll speak to, the latter two pieces I will speak to, if you will, have to deal with the readmission socioeconomic adjustment request that the American Hospital Association and also the American Central Hospital Association, which are basically the American Central Hospital Association, are your public hospitals or your hospitals that disproportionately depend upon DSH, the disproportionate share payment. They have asked, if you will, for CMS to do an adjustment in rate in reference to readmission rates and other quality measures for those who have a heightened concentration of those at low SES status or low socioeconomic status. CMS actually has refused to do that. So it has created this conundrum where hospitals feel that they could very well be penalized as it relates to their inpatient prospective payment for taking on lower income patients who have a higher readmission rate and may have a harder time meeting some of the quality measures that have been put in place. The reason why this is of acute concern is if this doesn't, if you will, go through, some of the hospitals fear that they may be forced, if you will, to make adjustments on how they look at their payer-provider mix. Now, I should mention that the NQF, the National Quality Forum, if you will, has been in support of the CMS's position. So it's not as if that CMS kind of did this without some sense of rhyme or reason, but it has raised an interesting conundrum, which is how best do safety net hospitals, if you will, kind of deal with this issue. And I would anticipate that this will be raging for some time. The reason why I brought this up in reference to Congress is because there currently right now are two bills that are pending. Last year they were introduced, but last year there were two bills that were pending, S-2501 and an HR 4188, that would have required this socioeconomic, if you will, adjuster. The other reason why this becomes an acute issue is because the majority of the hospitals that are disproportionately going to be impacted are actually in rural areas, not in urban areas. So that is, and then my last piece that I kind of wanted to put there, and I believe that Ron kind of mentioned this a bit, was the fact that Congress had put aside in the ACA about $12 billion to subsidize Medicaid payments for primary care providers and pediatricians up to the level of Medicare for 2 years, and that was agreed upon as a way of being able to do that. However, the subsidy that subsidy had actually expired December 31st of 2014, and so therefore the rates going back. Now, this would fall within the SGR or the doc fix situation, but this is an acute one mainly because this provision was solely put in there as an adjustment to the Affordable Care Act, and had not normally in past patches or fixes within the doc fix been an issue because it didn't exist before. So there's an acute focus, if you will, looking at that, particularly given the fact of the heightened need of primary care physicians to be able to shuttle and shepherd people who are now coming into the exchanges or coming into access because of the expansion around Medicaid, to be able to gain access and be rightfully navigate through the system. So with that being said, I thank you for your time and look forward to your comments, questions, queries, and criticisms. Thank you so much again.
Great. Thank you, AJ. We do have some questions that are coming in. Please feel free to enter them in the question box. I think what we'll do is maybe turn first to Ron, since you spoke first. There were a few questions regarding the King v. Burwell case. One was how there might be a different impact on different communities as a result of King v. Burwell. If for some reason there's an unfavorable ruling, Ron, do you see that there would be different impacts on different communities?
Well, I think, Kathy, the answer to that is probably, unfortunately, very clear. And that is, for those communities that are lower income and disproportionately communities of color, this is going to have a much bigger and more harmful impact, because it is low-income communities that are disproportionately receiving the benefit of the subsidies. And as I mentioned earlier, these subsidies are provided on a sliding scale. So therefore, the lower your income, the higher the subsidy. And if these subsidies were withdrawn, it is people who are poor who are going to lose a much larger subsidy than others. And of course, they're going to be in worse shape to afford the premiums without any subsidy help. So there's no question this will have a disproportionate impact on low-income communities and communities of color.
Yes. And another question that came up was, what about those states that have fewer APIs? And if we look across the map of where the federally facilitated marketplaces are operating, Texas has the third largest API population of any state in the country. And so we do know that there will be a large effect on, as Ron said, low-income APIs, and especially in those places where, like Texas, where there are sizable populations. There's also some questions about how to talk with clients and community members about the possible consequences of King versus Burwell if an unfavorable decision results.
So, Kathy, one of the things I want to emphasize was something you said earlier, and that is we've got our work cut out for us between now and March 4th. I say March 4th because that's the day oral argument will take place. The way the Supreme Court typically works is the Friday of the week where they hear oral arguments. The 9 justices sit alone in a room, and they take a tentative vote as to how they are going to rule. It is not a final vote necessarily, but that tentative vote is the vote that typically ultimately prevails, and they decide who's going to write the majority opinion and who's going to write the dissenting opinion. So our job between now and March 4th, when the oral argument occurs, is to get stories into the media about people who will be harmfully affected if the Supreme Court rules in the way that we fear. Now, this is a very different dynamic than some other challenges to the Affordable Care Act. You know, when different Republicans and opponents of the Affordable Care Act were trying to repeal the legislation, some of those efforts were made prior to the time that people started receiving the benefits of the Affordable Care Act. Well, now we've got quite a few millions of people who have received the benefits of the Affordable Care Act. And by the way, of the people who have enrolled in coverage in these federally facilitated marketplaces, the states where the state is not running the marketplace directly, over 85% of the people who enrolled are now receiving those subsidies. And so the overwhelming majority of these people are going to lose coverage, and because they are poor, they probably won't be able to afford coverage. Now, we have to make sure that people who are on this call who know of folks who are potentially affected and who will experience significant harm, that those stories get out there. We at Families USA have a story bank, and we are going to do a great deal to have front and center people who are in these states, who are now getting subsidies, who would become uninsured if they lose the subsidies, and especially those people with chronic health conditions whose lives could seriously be at risk if they don't get the health care they need. There will be an amicus brief filed on behalf of a number of people. You know, this is an extraordinary thing. You've got the two parties in this lawsuit are the opponents of the Affordable Care Act and the government. The people who are most harmfully potentially affected are not parties to this litigation. And so we've got to make sure that the people who will ultimately face the brunt of what the decision could be, that their stories are public and that the justices hear about that. There'll be an amicus brief filed on behalf of a number of these folks, but the more we can get out into the public's eye, the better it would be.
That's really helpful, Ron. And for those who want to contribute to either Families USA Story Bank, please feel free to contact Ron. And for us, you can contact Ian John at ijohn, I-J-O-H-N, at apiahf.org for us to be able to collect stories that are specifically for Asian American, Native Hawaiian, and Pacific Islander communities. So thank you, Ron. There's also some questions, AJ, for you. One is, can AJ speak more about the likelihood that the ACA definition of full-time work will change to 30 hours? I actually think that did pass the House. And then any information on how the Prevention Public Health Fund is being considered as a potential offset for, I'm not sure what SGR or even CHIP reauthorization?
Yes. So, forgive me for not highlighting the work hour rule. For those of you who have been following this, this deals with the definition that was included within the Affordable Care Act that basically said that an individual who works 30 hours a week should be considered full-time, and so therefore it allows for them to be kind of swept into a fuller coverage from a healthcare standpoint. The Republicans and conservatives, I should say, have taken certain issue with this, saying that a full work week is 40 hours, not 30 hours. Now there is, I would argue, the framers of the Affordable Care Act and who put it together probably didn't do as best of a job as they could have done in trying to explain why that provision was there and what was going on in the context of the time in what they were trying to get at. And so instead what has happened is that provision has become lampooned in such a way that I would argue has become quite toxic. To your point, Kathy, it has passed the House. It is currently under consideration in the Senate in reference to this, and the issue that is in play, and I would argue it's going to pass the Senate, that's not a question. They have a hearing scheduled, if you will, in the Health Committee next week on this very issue. So, so in all intents and purposes, this will pass the Senate. The bigger question is, what would the administration do? And here's why. The administration has come out and said that it believes the provision should stay because it undermines and will throw people who will currently be eligible for health insurance out of the health insurance consideration. That being said, I do liken this to a certain degree, like the provision, what was called the 1090s, if you will. That was a provision that was put in the Affordable Care Act, mainly as a cost saver, as a way of being able to bring more revenue, if you will, under the purview of the IRS for taxation purposes. In that provision, the administration stood up very vocally and said they were not going to go along with repealing that provision. And shortly after the 2010 elections, that was the first provision that the president gave up as a way of being able to bring compromise, if you will, to the Republicans. I feel that this provision is somewhat drifting to that direction, quite frankly. So I do think there's a high likelihood that that will be the case. And given the fact that more and more Democrats are feeling vulnerable on this issue, has become an issue. Now, I will say for Democrats who are up in the Senate in 2016, this has become a very, what do you call a litmus test issue, mainly because some of those represent in states that have a high level of seasonal workers, if you will, who kind of bump up against this 30-hour situation. And so I do think that is there. In reference to the prevention fund, well, the administration in 2 separate occasions in their budget had put up the prevention fund as something to compromise on and to give up on to fund other projects. So I don't think that there's going to be a lot of resistance in raiding the prevention fund. Let me stay with that. What I don't have a good sense on is the administration going to be particular about what the remaining funds in the prevention fund will be rated for? At one point, the most fervent defender of the prevention fund was Senator Harkin, in reference to protecting it and using it for its due purpose. But it appears as if with him no longer being there, that the reins of protecting that have kind of become hamstrung, if you will, and no longer as boisterous and as physical as they may be. What I would like to assure people that yes, some of it will be used for addressing either SGR or possibly addressing CHIP. I have no real sense of purview, at least at this point, on whether or not there will be that type of correlation. I think Republicans will likely probably use it for a different set of provision and priorities, if you will. And that maybe brings to a more broader discussion on whether or not reconciliation happens in the Congress or not, as a way of being able to take knocks at the Affordable Care Act, which under reconciliation rules, only things that can be considered are things that actually have revenue or have a score to them. And so that would technically bring that issue under purview, since there is money actually sitting there in the funded in the prevention fund for funding purposes. So it's really unclear. I wish I could give you much more granularity in terms of what that could happen there, but I don't foresee it surviving intact. I can tell you that.
Kathy, can I just add 2 quick which AJ was saying. First, with respect to CHIP and the Children's Health Insurance Program and extending funding for it, we don't have a precise so-called score from the Congressional Budget Office of what it would cost to extend it, but it is going to be minuscule because we have seen in previous assessments of what it would cost, it's relatively minor. So even a 4-year extension would be relatively cost-free. So I don't think that should be a problem with respect to getting the Children's Health Insurance Program ended. The other comment I quickly wanted to make is on this 30, 40-hour change. The proponents of the change from 30 hours being defined as a full-time worker to 40 hours have been saying this 30-hour provision has the impact, or has at least a potential impact, of having people losing hours of work because employers might, instead of having people work 30 hours a week, might work 29 or 28 so that the employer is not required to provide health coverage. The folly of this is that if you move the definition from 30 hours to 40 hours, there are far, far, far more people who work approximately 40 hours a week than 30 hours a week. And so the potential for harm is far greater. And one of the ironic things is you've got right-wing think tanks, which have generally been doing what they can to undermine the Affordable Care Act, who have been saying that this amendment that changes the definition actually is harmful. And so you've got a split within the ranks of the Republican Party and among some of the thought leaders on the right wing who are saying this actually is an amendment that is going to be significantly harmful if it ultimately were passed.
Thank you. And then one more question about clarifying, AJ, your comments about mental health and parity in particular. Did you see that?
I didn't, for some reason, I don't.
Oh, okay. It says,
question.
I'm confused by AJ's discussion on the mental health services changes, given that the ACA requires compliance with the Federal Mental Health and Addiction Parity Act. Can he address that?
So this has been a rub for something, and let me kind of go back to my history on this. So I was involved with passing the Mental Health Parity Act, the Paul Wellstone Mental Health Parity Act, when I was working in the Congress. And at the time, as you know, it makes mandates on the private side, but doesn't make mandates on the public side. And one of the issues that has arisen, if you will, with the row that has arisen within the mental health debate post a lot of these, again, shootings and those kind of things, is whether or not now requirements should also be filtered through to both the public programs as well as the private programs, and then how those requirements are going to be fettered out. Will it be left up to the hands of the states, if you will, to come into compliance under their own structures, or will it be left into the hands of the federal government to bring, if you will, some sense of national standards about how those services should be administered and how those programs should be authorized, if you will, for accessibility. Now, the issue that has come, the reason why this becomes an issue is because funding right now for mental health programs, with the exception of those that are included within Medicaid, is discretionary. And so there's a question on where exactly the funding will come from. And this is all being done, if you will, in the absence of a long and way overdue reauthorization of SAMHSA, which has not occurred, even though many valiant attempts have been made. So that is, if you will, is what's kind of caused some sense of confusion exactly on what direction kind of move forward with. Now, Republicans, I will say, want to go this way because it gets the gun issue, quote unquote, if I may say that, off the table for them and kind of removes them having to then think about broader issues in reference to gun control, because they can say that they at least address this issue around mental health and providing mental health services. So therefore, you have less individuals who may have mental health problems, if you will, being able to get access to firearms and the like. But Democrats, I think, have been very much focused on doing something much more expansive to also make sure that those services are not just only solely for the purposes of addressing some concerns around gun control access, but much more thoughtful about how do we issue the issue around parity, and then more importantly, how do we support the need for greater access for mental health services. There are some states like California which are much more expansive than a number of other states have been in reference to what they cover on the mental health service side. So I think that there's pent-up frustration that if the only thing the mental health community gets in terms of a victory is this, that's woefully short in what they ultimately will need. And then just to kind of piggyback on Ron's comment about CHIP, he's right. The actual extension itself wouldn't cost a lot. However, I think for those of you on the phone, many of you have been advocating for add-ons, for instance, or expansions of certain benefits like dental or vision issues and also language access services, etc. Those things would cost. And so those things would likely need to be addressed in some way, and potentially the prevention fund could be something to be looked at. But again, it's unclear exactly would that be steered to or not.
Well, thank you. We are at time, and again, I really want to thank Ron Pollack and AJ Jones for joining us and really sharing with us their perspectives and experience. I want to emphasize again on the screen, we've got check out our website, and if you have been tweeting, keep doing that. And Ian, when is the YouTube video going to be posted?
Yeah, the recording should go up next week, beginning of next week. So it will be available from our Healthcare for Me site you see on the screen there, and also from our YouTube channel, which is www.youtube.com/APIAHS.
So thank you again, everyone, and go help and get people covered and enrolled. Thank you.
Thank you so much. I really appreciate it.
Thank you.
Bye-bye.